So measuring overall functioning across domains, looking at physical functioning, role limitations due to physical health, emotional health, energy, social functioning, pain and general health, using the SF-36, which is a well-used, widely evaluated patient assessment instrument, which is used, I think, in more than 4,000 different papers now. So, and it's also been used extensively in research into people with ME. So here we have, just shows you an example of how debilitated people with ME in general are. This is a group of ME patients here, 21 from my research. In terms of physical health, they're scoring about 30, whereas the blues, healthy controls, are scoring up to sort of about above 90, a healthy control, so certainly above 85 would be someone in pretty good health. The red is in comparison to major depressive disorder, MS and congestive heart failure. So we've got these very low levels here for people with ME, particularly in the role limitations. So their ability to carry out physical tasks is extremely limited in people with ME. Emotional well-being and emotional functioning, and these are their strengths. Obviously, vitality, energy and fatigue is very low. Social functioning is highly impaired in their inability to be able to function outside the home. They have quite a severe burden of pain, and their perception of their own health is poor. So the importance of defining fatigue as well, so using multiple instruments, things like the fatigue severity scale, and that measures intensity of fatigue and functional incapacity of the patients, and also using multiple measures, because there's a ceiling effect. In most measures of fatigue in patients with ME, there's a ceiling effect, so they hit the maximum, so even if they were to actually get worse with an intervention, you wouldn't actually know. So I also use an analog fatigue scale as well, very simple. Also use the HAD scale to look at people's emotional functioning and how well they are emotionally. But also taking care that we don't confound those with symptoms of depression, which can be an issue there. And patient gathered information, so they're able to use things very simple, things like pedometers. I did actually look at using actimeters, but they're about £2,000 each, so that's not. But simple pedometers for measuring before and after to look for increases. Body temperature. Patients with ME often report that they have a low body temperature, or they feel very cold. But it's actually quite a difficult thing for them to do, particularly with the high level of debility they have, particularly in the mornings. To actually ask them to do this maybe 3 or 4 times a day is quite difficult. You can tell us how many hours they're using, and the Bell scale, this modified Kronowski scale that I mentioned. Okay. And from the assessor's perspective, everything has to sort of fit together and make sense across these multiple measures. So the symptoms need to make sense with the fatigue scales and the different measures across the different domains, and need to explain any discrepancies. So I'm going to move on to just the first case study today. This is a female in her 50s, and she asked me to assess her before and after she decided to do an intervention with Gcmaf. She was able to work part-time self-employed for about 10 hours a week prior to intervention. She had a history of breast cancer back in the late 1990s that was successfully treated. She had sudden onset ME in 2008. About 70-80% of patients have a sudden onset of the condition, whereas about another 15-20% have an onset over a longer period of time. And she had moderate to severe ME, and she met the Canadian consensus criteria. She had no evidence of elevated distress, whether had anxiety and depression score of 6 and 5. And these were some of her worst symptoms, was reported back in January 2012. So post-exertional malaise, this long recovery, the weakness, flu-like fatigue after even basic activities, the activity of daily living, and certainly in response to exercise. Cognitive dysfunction, pain, particularly headaches, joint and muscle pain, non-restorative sleep, sensitivities to food, medications and sound, blurred visions, and also some periods of breathlessness without physical activity. So she undertook 6 months of Gcmaf treatment and asked me to reassess her. And prior to the Gcmaf, her symptom score was 83.5, and after 6 months of Gcmaf that had gone down to 8. This is an effect size of 13.2, which is an extremely large effect size, and also takes her down into the normal range, which is between sort of essentially 0 and 16. So this is a huge, massive reduction in symptoms and a massive improvement in quality of life for the patient. Fatigue severity was 6.3 out of a maximum of 7 before. That's reduced to 2.4. Again, a huge effect size there, 3.1, and well within the normal range. VSF 36, physical functioning before Gcmaf was 25, now at 85. That's within the normal range of about 84. Again, large effect sizes. Role limitations due to physical functioning was 0 before, so completely, really inability to do any form of physical activity at all. And this has moved up to 25, which is a moderate effect size change, but we've discussed this, and it's probably more to do with just confidence and getting rehabilitated and back into the world, and hopefully that will improve over time. So still some way to go to get to normal level there. Energy and fatigue gone from 10 to 80, large effect size. And emotional well-being was already a strength, and that's not changed. Social functioning, his ability to interact in the world is improved with a large effect. Pain has reduced with a moderate to large effect. There's still some issues with pain. In general health, impression has gone from 30 to 80, which is actually above the norm. And Bell's scale's gone from 30 to 40 up to this sort of 80, so 80 to 90 on a sort of modified Karnofsky scale. So huge improvement there in reduction in symptoms. In terms of the neuropsychological test results, this is one of the particular tests of attention that I would use is a Stroop test, and there's 3 parts to that. One of them is the word test. So at the beginning of the first assessment, she was scoring the 23rd percentile. We'd expect her to score between the 74th and 99th percentile. So this is just on a normal curve. So you're scoring very low, not an impaired. Impaired would be down here, but much lower than we'd expect for someone of her age, intelligence, and education. And after the Gcmaf, she's up in the 95th percentile, so absolutely right on where we would expect her to score in this region here, and a very large effect size of 2.3. And this is in a test which has a very high test-retest reliability, so if she scored really here before without any intervention, you'd really expect her to score in the same. And moving on to the colour part of this test, prior to Gcmaf, she was actually in the impaired region, so less than the 5th percentile, so right down here. And then afterwards at the 74th percentile, so we're just at the bottom end of where we'd expect someone of her to be scoring, and a very, very large effect size there of 3.9. And a very similar thing with the Purdue pegboard. This is a measure of fine and gross motor control, speed, dexterity, and an ability to work with both hands together simultaneously. So quite low here, then in the 20th percentile, and after Gcmaf, treatment up in the 92nd percentile, so again with a large effect size. On the other 10 measures that I look at are neuropsychological performance, improved with effect sizes ranging from 0.2 to 2.8. The modest increase there from 0.2 is in a particular measure that was fairly close to normal pre-Gcmaf. And only one measure post-Gcmaf was below expected, and that was just at the 72nd percentile, so quite near where we'd expect anyway. And she passed all measures of effort pre and post assessments. So other objective measures, so before Gcmaf she was doing on average 2,500 steps in a day, post 7,700. That's a very large effect size of 12.9. That's a really huge difference in her ability to be active. Body temperature has increased, and prior to Gcmaf on day 1, she undertook the stair test, took 43 seconds and was unable to do it on the second day. She was too debilitated. On day 2, post Gcmaf day 1, taking 30 seconds, and on day 2 she was actually able to do it faster at 27 seconds. So it's a really big reduction and an improvement there in her ability to carry out a little short, sharp exercise test. Prior to Gcmaf, she's working 10 hours, and now she tells me she's in the 50 to 60 hours a week, so able to really do a lot. And here's the body temperature on a graph, because not also is it increased in temperature generally, but it's also changed in the way the temperature works throughout the day. So prior to Gcmaf, we had these ups and downs, and it seemed to have regulated into something which is more of a more normal pattern of body temperature